Can unilateral adrenalectomy be an option in modulating autonomic nervous system in heart failure? Let me start off by posing a question. Do we need to go far in thinking and coming up with newer concepts to treat heart failure? The simple and quick answer is yes. This is dictated by the fact that heart failure is a devastating problem, is common and costly, is growing in numbers and severity. Why is the focus on cardiac autonomics, and in specific the sympathetic system? That is because in heart failure and among many activated hormonal pathways, the activated sympathetic system is believed to be the most important and the hardest to sufficiently antagonize. The beneficial impact of targeting the sympathetic system is evident from the proven role of beta blockers. The role of beta blockers in improving outcomes has changed the treatment landscape of chronic heart failure. Recently, a new strategy focusing on targeting the autonomic nervous system and sympathetic activation associated with heart failure has gained a momentum. Current targets to modulate autonomic nervous system include vagal nerve stimulation, carotid baroreceptor stimulation, spinal cord stimulation, and renal denervation. While being enthusiastic about these potential modalities, we need to be aware of the fact that these are invasive, investigational, and fraught with many unknowns. In general, and while device-based therapy for heart failure in the form of implantable cardioverter defibrillator or ICD and cardiac resynchronization therapy or CRT has offered a clear benefit as demonstrated by many clinical trials, their associated healthcare costs and morbidities are also very well recognized. Therefore, is it not a dream to find a one-time, effective, and safe procedure that can modify the sympathetic activation in heart failure? The search for such a procedure has long been sought. Renal denervation is an example, though it may have been a disappointment. Recently, selective carotid body ablation has been proposed. Herein, and based on the evidence to follow, I suggest that unilateral adrenalectomy is an option in modifying sympathetic activation in heart failure. A major role of the sympathetic system is exerted by epinephrine and norepinephrine released in the bloodstream from the adrenals medullas. The adrenal medulla is the single largest source of epinephrine and norepinephrine in the body. While the rapid response is mediated by catecholamines, epinephrine or epinephrine secreted from the adrenal medulla may be necessary for survival in the fight or flight response. Sustained elevation of these circulating catecholamines for a prolonged period of time can produce pathological conditions, such as cardiac hypertrophy, hypertension, and heart failure. The role of adrenalectomy to alleviate heart failure is well documented in pheochromocytoma, Cushing's disease, and Cohn syndrome. The role and association that incriminate the adrenals medullas in the etiology of hypertension and heart failure outside the aforementioned diseases was recognized a long time ago before the era of effective antihypertensives. Between 1914 and 1950, unilateral adrenalectomy and different combinations and degrees of adrenalectomy and sympathectomy were attempted in patients with severe and intractable hypertension. The results were promising. Furthermore, it was concluded that adrenalectomy may be an important factor in the relief of heart failure. Please refer to the published paper for more details on these previous studies. The suggestion that unilateral adrenalectomy is an option in modifying sympathetic activation in heart failure warrants consideration. Unilateral adrenalectomy may be a good target to achieve a more sustained alpha and beta blockade in addition to some aldosterone blockade. Ablation or removal of one adrenal gland is very likely to preserve the adrenal cortical function and avoid a complete sympathetic depletion, which may be counterproductive in heart failure. This slide shows a simplified flow diagram of an example of ischemic heart failure model in mice and the different steps involved in the suggested experiment. This final slide is not included in the published paper. It highlights the fact that adrenal artery embolization is an alternative to adrenalectomy in humans. It is a non-effective, less invasive, safe alternative or adjunct to surgery for several indications, including palliative adrenal tumor control, suppression of excess adrenal hormone production, and hemostasis of ruptured adrenal tumors, traumatic adrenal injury, and adrenal artery aneurysm occlusion. The picture on the left depicts the arterial supply of the adrenal gland. The one on the right illustrates a successful microcoil placement in the inferior adrenal artery in a patient who had hematoma after adrenalectomy performed for adrenal adenoma. Thank you for listening.